Welcome to Healthcare Update with Layla Kramer. Each episode brings you informed commentary on the most recent issues in healthcare and public health, as well as in-depth interviews with prominent experts. And now, here is your host, Layla Kramer.
Hello, my name is Layla Kramer, Executive Producer for the National Library of Patient Rights and Advocacy. Today, my guest is Dr. Millicent King Channell, Vice Dean for Academic Affairs and Student Services at Rowan-Virtua School of Osteopathic Medicine in Glassboro, New Jersey. Dr. Channell is a distinguished leader in osteopathic medicine and medical education. A graduate of Philadelphia College of Osteopathic Medicine, she holds board certifications in family medicine / osteopathic manipulative treatment, OMM, and neuromusculoskeletal medicine / osteopathic manipulative medicine. Her career spans key academic and leadership roles, including Residency Director, Department Chair for OMM, and co-author of the 5-Minute Osteopathic Manipulative Medicine Consult. Dr. Channell has made significant contributions to the profession, including serving as the 2023-2024 President of the American Academy of Osteopathy, AAO. She's also been appointed to the U.S. Department of Education's National Committee on Foreign Medical Education and Accreditation. Today, we are going to talk to her about the different state of medical education and the differences between the medical education of an osteopathic physician and an allopathic physician in MD. Welcome, Dr. Channell, and thanks for joining us today.
Thank you for having me.
So I guess my first question is, in light of all that is happening in healthcare right now, do men and women still want to become physicians?
Absolutely. We see our applications up, certainly here at Rowan-Virtua SOM and across the osteopathic community and nationally.
And then what are the demographics that you're seeing in students applying to medical school?
Well, since about 2018, women have outnumbered men in the number of applicants as well as in the number of people who are actually enrolling in medical school. So women make up about 55% of those who are enrolled in medical school right now. We also still see an increase in diversity both by gender, by race, and by economic classes. We still see the predominant number of people or percentage of people coming from high-income families still predominating the people who are in medical school, but we're seeing some more diversity among different economic classes, which is great.
And do you think there are any reasons why those demographics are the way that they are?
I think people recognize a greater need for diversity in medicine, and people are feeling that it's more accessible. Of course, with the internet, there's more information available to people and more access. There are more pathway programs for people to access. And we're seeing more diversity in the pathways that people take to medical school. So more and more people are taking a year off or a few years off before they go to medical school. It used to be pretty straightforward. You went straight from college, straight into medical school. And what we're seeing, what we used to call a non-traditional student is actually becoming way more common, which is that people have at least a year off between medical school, sometimes several years off, and get another degree or have other job experiences before they come to medical school.
Thank you. So what is the difference between an ADO and an MD?
So a DO and an MD, DOs are osteopathic physicians and MDs are allopathic physicians. DOs are specifically created and founded in America. It's sort of like jazz music. So we were founded in the 19th century by Andrew Taylor Still, who himself was an MD. At that time, you have to understand that there were multiple types and classes of medicine being practiced. Allopathic medicine, eclecticism, homeopathy, chiropractic medicine, etc. Over time, some of those evolved and expanded, and some of those contracted or were subsumed by other groups. But today, there are two types of fully licensed physicians in the United States, DOs and MDs. That means that they can go into any specialty, cardiology, pediatrics, general surgery, orthopedics, family medicine, whether they're a DO or an MD. Both get trained in how to take a history and do a physical exam. Both get trained in how to make a diagnosis through a history and physical exam or through laboratory work or other testings like EMGs or EEGs. Both get trained in how to treat with medications or surgeries or procedures or with lifestyle medications. The biggest difference is in the explicit and consistent philosophy of osteopathic physicians, which recognize human beings as mind, body, and spirit, and we incorporate that in how we approach our patients and putting patients' goals first. The second component is in learning how to diagnose and treat with our hands. So I have a board certification in family medicine, and I have a second board certification in osteopathic manipulative medicine. You don't need a second board certification in manipulation. All DOs can treat with their hands. I just happen to take it to a specialization. That means if you come in and see me and you have a headache, I can certainly make sure that you don't have a brain tumor, that you're not having a stroke. I can certainly treat you with medications for migraines or tension headaches. But it also means that I can examine you with my hands, and there are certain techniques I can do to stretch muscles, to realign the skeletal system, to help decrease your pain. And that becomes really important in a lot of populations who are really sensitive to medications or can't take medications. So when you think of very young children or the elderly who are often on several medications already, or who may have medication interactions, or when you think of pregnant people, often if they have pain, which they do, there's nothing that people can give them in terms of medications, but we can treat those patients with our hands to help alleviate their pain or to help improve their outcomes in terms of delivery. So those are all part of the basic training that we get as part of our medical school training, in addition to what people would consider the standard training in medical education.
Thank you. Why do you think some students apply to osteopathic medical schools and others apply to allopathic schools?
I think there's a lot of overlap in the people who apply to both DO and MD schools, and certainly people have different priorities in terms of the cultures of the different schools and what they're focused on. That can also include geography and location. But I think what attracts students to DO schools in particular is the focus on mind, body, and spirit, and is on the focus on community. Also, historically, our schools tend to be in more rural and underserved areas. That's where we tend to found our schools. And so it makes it more accessible to students to come from their local area and stay in their local area for their training, and gives them a sense of community because many times their faculty are from those areas as well.
Thank you. Today I know DOs work side by side with MDs. Was there a time when that was not the case?
Absolutely. And so, you know, if you walk into our hallway, you'll see a history of osteopathic medicine in our hallways. And there's a wonderful book that we actually require all of our students to read called The DOs in America by Norman Gebetz, and really talks about the evolution and the politics, quite frankly, around the practice of medicine in America. Not, again, just with DOs and MDs, but across several practices of medicine. When I was a medical student, which wasn't that long ago, there were still osteopathic hospitals that were founded specifically for osteopathic physicians to practice in. Today, that doesn't exist. We're all working side by side, but that was an evolution over time.
Finally, in your opinion, what is the future of medical school education, especially with the current issue of a shortage of physicians?
Sure. So I think the osteopathic community does this really, really well. One is, again, as I said before, we tend to be founded and established in more underserved and rural areas. And I think that's really important because they're attracting people who are more local to those areas and giving them access. People are more likely to practice where they train, both in medical school as well as in residency. The other is, I think we're going to have an increase in class size for a lot of programs wherever that's possible, as well as branch campuses. Again, I think the osteopathic community does this really, really well in terms of expanding class size and in terms of having branch campuses to have more regional locations. Historically, if people are interested, they can look into the Flexner report, which defined what the standards were for medical education. But it really focused on having academic universities as the focal point of medical education. I think that's fantastic for research. However, when you're talking about trying to create family doctors, primary care doctors, or even specialists for rural and underserved areas, you really have to move away from that model so that those people and those populations and communities can have access to care. And finally, I think that we're going to have to look at, how we train physicians. AI is not going to eliminate physicians no more than the internet did. But certainly we're going to see more and more integration of AI into the training of physicians. It's not going to be about recalling individual facts. It's going to be about clinical reasoning, ethical judgment, and really personal relationships.
And how do you feel about that, about them wanting to put AI into this type of education?
It's just a necessary occurrence. I mean, it's just like having the internet and saying that you're not going to use the internet as part of medical education. We really have to teach people how to use it, that it's not thinking for you. How do you use it as something that can help you with critical thinking or as a study aid? And there's lots of ways to do that. How can faculty use it to help develop questions or testing or resources for their students? How can you use it at the bedside to get the best information? And there's different platforms that are more appropriate for different causes and purposes. And so helping to teach our faculty and our students, what is the time, place, which different platforms do you use, and in what way do you use it in order to provide the best care to patients and in order to help our trainees as they move through the process.
Thank you. Well, thank you, Dr. Millicent King Channell, for being my guest. This has been a very interesting conversation. I'm Layla Kramer for the National Library of Patient Rights and Advocacy. Thank you so much for joining us.
Thank you.